Alex. I'm here with Christie Tate, nurse practitioner. We're going to do the next session of our Migraines from Both Sides series, and we thought we needed to really focus now on preventatives and what we mean by preventatives. Both of us have had experience of being on preventative medications to reduce the frequency and severity of our migraines. But what is the difference between a preventative, for example, and something we take when the migraine occurs? Christy, do you want to get started on the explanation about those differences?
Yeah, absolutely. What we call sort of acute medication or your as needed medication, these are the things that I always say is like your fire extinguisher. You keep that for when you have a migraine attack. Every migraine sufferer will need something. Sometimes, people will respond to something over the counter. Sometimes it needs to be prescriptive. There's a whole family of medications called triptans. There's prescriptive anti-inflammatories, and that is kind of our arsenal. There's several different ones, but that's what you take when you have a migraine attack. Now, the thing about the kind of shortfall of these is that you can actually make your migraine attacks more frequent or worse by using these medications too often. So they help you during an attack, but they don't tend to reduce the number of attacks you get in a month. So once you start having more frequent attacks, and the American Headache Society says, if you're having about 4 migraine attacks or more a month, or your function is impacted, then maybe it's time to start thinking about what we call preventative medications. We have several different options. The ones you most commonly encounter are ones you take orally, and these oral medications are taken every day. Jackie, do you want to tell us a little bit about, the different kind of classes of medication and how we decide?
Yes. Um, Before I do that, I'm just going to say that from my perspective, and I probably get about 4 migraines a month, maybe three, even on preventatives, by the way. I'm very cautious about how much I take in terms of that anti-inflammatory medication. Anti-inflammatories are often available across the counter, and I limit myself to taking no more than, say, 5 doses per week of an anti-inflammatory, because I might need to take two in a day, but usually three is what I would limit myself to. And the triptans, which are the migraine designer drugs that take a migraine away, I'm lucky enough to respond to, and I'm lucky enough to have a drug plan that covers them because they can be pretty expensive and they're not available to everybody, and certainly not in other countries perhaps as well, but it really depends on whether you can afford them. And again, with triptans, they can cause rebound as well, where the headache comes back and back if you take them too often. So with the triptans, I limit myself to an absolute maximum of three a week. So if I did happen to have 3 migraines in a week, I actually would probably only medicate two of them and use ice packs and darkened room for that third one, if I possibly can. Now, if I'm teaching, if I'm away somewhere and I absolutely have to, I might allow myself to take that third. But it's because I'm trying to avoid rebound that I'm doing that so cautiously. And it was back in approximately, well, 5 years ago, actually, for me now, that I ramped up on the frequency of my migraine headaches. They were coming on for the slightest reason, the slightest raise that I had of stress, because I had just been through my brother's premature death. I was coming into retirement and designing what that would look like. I had a new grandchild. Certain things came together at that time to cause me to understand that I really needed to get on a preventative in order to reduce the frequency. And so I chose which one I wanted and negotiated with my family physician, because many of these preventatives are in the blood pressure lowering class of drugs and are being used as preventatives for migraines in a way that we call off-label. They weren't originally marketed by the companies that make them for migraine prevention. It just happened to be realized that they did this as well and then got researched. And so there has been quite a bit of evidence to show that some of these drugs are as useful for migraine headaches, prevention or reduction in frequency, as they are for the original reasons they were developed, which is usually blood pressure lowering. But actually, you can mention some of the other classes, Christy, that you
Yeah,
prescribe?
you made a really good point, right? Because there's a couple things that I see. So the kind of common classes, the antihypertensives, which are your blood pressure medications, antidepressants. So we often use a class called the tricyclic antidepressants, which weren't actually as great as antidepressants and tend to be used more for migraine prevention or pain. And then sometimes anti-seizure medication. So it's very common, you know this and I know this, that we take medications that might be categorized, but we use them in different ways because they can be effective that way, and sometimes even more effective for those things than their original class. But I think what is maybe a little bit off-putting as well to individuals, and I've seen this in patients that have come to me and said, "Well, I was prescribed this antidepressant. My migraine is not because I'm depressed or I'm anxious, so that's not the right medication for me, or it's not because I have high blood pressure." And I think then that's, we've not really done our job as healthcare providers explaining how or why we might use these medications. So they can certainly be effective. Sadly, we don't have a really good algorithm to know why, you might respond really well to that medication, Jackie. I might do better with a different one. So it's a little bit of an imperfect trial and error sometimes to find that right preventative. We know that they can work, but again, because they're not specific, they may have certain side effects. So you have to sort of try them. The ideal scenario is you don't have any side effects and you have good response to your migraine, but sometimes it's a little bit in between there. And
Yes.
sometimes people have to stop them because they don't like how they feel.
I chose mine, and because I had that experience of what was out there, I chose mine based on the fact that I knew there was a little burst of my stress hormones, adrenaline, that was coming too frequently during the time that I was suffering these very high frequency and intense migraines the year after my brother died. And so I actually chose one that blocked that. And it was very effective indeed. But I had surveyed the literature that did research whether this medication could be used as a migraine preventative. I actually felt that that particular medication might be used as a chronic pain preventative because stress often brings on chronic pain so profoundly. So I think it's underused, and it's a very, very inexpensive generic medication. So I was really happy to find one that worked for me to reduce the frequency and to reduce the intensity. And the other thing that I had found during that time of highly frequent migraines was I developed a depression, and the depression actually didn't come in that way that you would say, well, sure, you're having loads of migraines, why wouldn't you be depressed? Every day you were just on the brink. But in fact, researching the literature again, there is a depression associated with migraine headaches that goes when you are on a preventative, for migraines, and not even one that is an antidepressant. So I do believe that my depression was a migraine related depression rather than the sort of depression you would take an antidepressant for. My preventative lasted about a year and a half before I had to add in something more. It wasn't that it was coming back profoundly, but I did feel my brain was now at a lower level of being able to bring on the migraines, that the threshold to migraines had gone up, which was good. But I did have to add on something else, which was also off label, but became on label. These were the injections for migraines, but they weren't injections of the local anesthetics. These were botulinum toxin injections that was added. And again, you have to have a drug plan to cover these because they can be extremely expensive. Back to you, Christy.
Yeah, I think, you mentioned a couple things too. So, um, there are beyond the oral medications, other medications like these injectable medications. So on botulinum, there's a class of medications, the CGRP monoclonal antibodies, that are newer to market in the last 3 years. I think it's in a very interesting and kind of exciting time for migraine sufferers because I think this says we're learning more about the process of migraine. There are new medications in development. Our neighbors to the south in the States tend to have more available market now, and there will be more coming to Canada. So, migraine sufferers are sometimes left to kind of navigate and manage their care on their own. And I think even though you're a healthcare provider, you did your research, you went to your healthcare provider to, ask for medication. And I find that many migraine sufferers come to me and they have questions about these medications. They've seen, certain commercials and they've heard of things. And so I think that's good. It's truly how you should collaborate with your healthcare provider. You know yourself and your illness, and it's okay to ask about these things. So, um, you know, despite all of that, I think that there's still a lot of apprehension about the idea of taking a medication on a regular basis, and what does this kind of say, and is this just something I'm giving into and accepting for the rest of my life? And you don't have to necessarily be on a preventative forever. I think you can get into a state where things are better controlled and it can be reevaluated. So when people ask, how long do I have to stay on this for? Once you have good control, it's usually about 6 to 12 months before you want to start making changes. If you are in a good place and you take things away too quickly, it can just kind of upset the apple cart and everything falls back again. But, I think it's reasonable to reevaluate after, you've been in a good place. Maybe you've reduced the dose a little bit, or, space out some of your injections a little bit. So that can be done to get people back to function. But you almost need, I don't know if you felt like this, Jackie, but when I needed prevention, I just couldn't get my head above water. Like, just everything was triggering an attack. I was using my acute medication, I knew, way too often, but I couldn't get through my day without it. And then by the end of the day, I just needed to go to bed. So, that suffering I don't think has to happen, right? And I felt much better after I started preventative treatment. And the other thing that happened is my acute medication works better. So when I have an attack, it actually gets rid of my migraine attack, as opposed to what I would say before, just kind of taking the edge off, right? So it would take me from a here to a here, and that was the best I got out of it.
Yeah, I agree. My acute medication works better. I don't get quite as an intense migraine headache, but I did notice that the preventatives were better at the beginning. And yeah, so I will see where I go. I'm still on my preventatives, two of them, and I'm very grateful that I have a drug plan to cover them. The monoclonal antibodies would be my next step, the anti-CGRP that you mentioned earlier. And that, by the way, caters to the biochemical difference that we have as migraine sufferers compared to those who don't have migraines. So there is a biochemical, I guess, imperfection. That's almost a word I'm not sure I would use.
Difference.
Yeah, because I don't like to suggest we're imperfect, but there's part of our biochemistry that's off, and hence, we've had to collaborate with that for our entire lives, and things are getting better as we get older in terms of what we can access. But I would say that those monoclonal antibody medications are extremely expensive and therefore are not available to all. May in fact not be available to many at this point, but things do tend to get more genericized and cheaper as time goes by. Let's leave it there because I think we can still do some more discussion of this. We could go on forever, actually, in a future session. Okay, bye
Take
for
care,
now.
Jill.